Hello everyone. In this class, we'll learn about cardiac cycle. Cardiac events that occur from beginning of one heartbeat to beginning of next are called cardiac cycle. Each cycle is initiated by spontaneous generation of action potential in SA node. The orderly depolarization triggers a wave of contraction and relaxation. With an average heart rate of 75 per minute, duration of one cardiac cycle will be 0.8 seconds. Cardiac cycle include electrical as well as mechanical event. Electrical events that are followed Electrical events are followed by mechanical events. The mechanical events are pressure changes in the atria and ventricles, pressure changes in atria and pulmonary artery and jugular vein, volume changes in atria and ventricles, and movements of heart and production of heart sounds. The cardiac cycle is depicted in this particular diagram where it is showing atrial systole, the atrial events like atrial systole and atrial diastole, and ventricular events such as ventricular systole and ventricular diastole. Atrial systole is of 0.1 second, atrial diastole of 0.7 second, whereas ventricular systole is 0.3 second, ventricular diastole is of 0.5 seconds. Ventricular systole, again, it consists of different phases, like it includes isovolumetric contraction phase, rapid ejection phase, slow ejection phase, then a protodiastole, isovolumetric relaxation phase, first rapid filling phase, diastasis, and last rapid filling phase, which corresponds with atrial systole. Atrial systole. Atrial systole can be as the initial phase of cardiac cycle. Before atrial contraction, AV valves are open, semilunar valves are closed, and blood flows continuously from great veins to atria and from atria to ventricles. 70% of the ventricular filling occurs before atrial contraction. Atrial systole contributes only 30% of the ventricular filling. Atria simply acts as a booster and pumps that increase the effectiveness of ventricular filling. Atrial systole causes an elevation of atrial pressure which is recorded as a wave in the atrial pressure tracing. Here there is some regurgitation of the blood into the great veins which is minimized by constriction of the vena cava during contraction of atrial muscles. Atrial systole starts after P wave in the ECG. Ventricular systole. Atrial systole is followed immediately by ventricular systole, and it is divided into three phases. That is isovolumetric ventricular contraction, which is around 0.05 second. After the onset of ventricular contraction, the pressure in the ventricle rises abruptly. This causes increase in interventricular pressure above the atrial pressure, which causes closure of AV valves and thereby first heart sound. The semilunar valves are already closed, so the ventricle is a closed chamber now. The ventricular muscles are contracting, but there is no change in the length of muscle fiber. So that is why it is isometric contraction. There is no change in volume also, so this phase is called as isovolumetric contraction phase. During this phase, there is a sharp rise in interventricular pressure. AV valves bulge into atria, which causes a slight increase in atrial pressure, and this is recorded as a C wave in atrial pressure tracing. The interventricular pressure rises sharply, and when it exceeds aortic and pulmonary arterial pressure, semilunar valves open. Maximum or rapid ejection phase, which is around 0.1 second. When semilunar valves open, initially the pressure gradient is more and the blood enters rapidly into aorta and pulmonary artery. So this phase is called as a rapid ejection phase. Although the duration of rapid ejection phase is less, 70% of the ejection occurs during this phase. Aortic pulmonary uh, Aortic pulmonary arterial pressure increases as the blood enters in them. There is a marked reduction in the ventricular volume. The next phase is reduced or slow ejection phase, which is around 0.15 seconds. 30% of the ventricular ejection occurs during this phase. Ventricular pressure begins to fall or when it becomes less than the aortic and pulmonary arterial pressure. The momentum keeps the blood flow for some time. Ventricular volume continues to fall. Ventricular diastole. So this includes four phases. That is, first one is protodiastole phase, that is around 0.04 second. Ventricle starts relaxing, ventricular pressure reduces rapidly below the aortic and pulmonary arterial pressure. When momentum from flowing blood is overcome, semilunar walls close. So, protodiastole is the short interval between the ventricular diastole and closure of semilunar walls. The closure of the walls is sharp, and this leads to rebound of blood column, which is represented as a sharp deflection called incisura in aortic pressure tracing. Then isovolumetric relaxation phase, which is around 0.06 second. It starts from closure of semilunar walls. AB walls are already closed and ventricle is again a closed chamber. As there is no change in volume, it is called isovolumetric relaxation. There is a sudden reduction in the pressure, and when it becomes less than that of atrial pressure, AB valves open. As AB valves open, there is a rapid entry of blood into ventricles. It marks the end of isovolumetric relaxation. Then ventricular diastole proper, that is around 0.3 second. So in that we have first rapid filling phase and reduce filling phase, that is called as diastasis. First rapid filling is around 0.1 second. As AV valves open, the blood flows rapidly into ventricles. It is due to more pressure gradient and ventricular volume increases. Atrial pressure will decrease, but it is still higher than the ventricular pressure, which results in the production of the third heart sound. In reduced filling phase, that is in diastasis, ventricular inflow velocity decreases, volume increases gradually, but flow into the atria through superior vena cava and inferior vena cava and pulmonary veins. From atria, blood flows into the ventricles, and all these acts as a single chamber. Last rapid filling phase, which is around 0.1 second, it corresponds to atrial systole. Due to the atrial contraction, velocity of flow into ventricles again increases. 30% of the ventricular filling is contributed by atrial contraction, and it is going to coincide with the fourth heart sound. Coming to pressure changes in the atria, the atrial pressure changes can be studied by pressure changes in the internal jugular vein, which is similar to atrial pressure tracing, as it is a retrograde transmission of atrial pressure changes. Atrial pressure rises during atrial systole and continue to rise during isovolumetric contraction when AV wall bulges into atria. When AV walls are pulled down by contracting ventricles during ejection phase, the atrial pressure falls rapidly. The pressure then raises until AV walls are again open. Then pressure raise in atria decreases. The atrial pressure changes are transmitted to great veins, producing three positive, that is A, C and V, and two negative waves X and Y. In jugular pulse tracing, A wave is due to the atrial systole. Pressure in the jugular vein also increases as some blood regurgitates during atrial systole. In addition, venous flow stops and resultant rise in the venous pressure contributes to A wave. C wave, it is manifested as due to the rise in atrial pressure produced by bulging of the AV wall into the atria during isovolumetric contraction. X wave is the first negative wave and it occurs due to the downward movement of AV ring during ejection. V wave is due to the passive increase in pressure due to the venous return, and Y wave is due to the emptying of atria as AV valves open. Jugular venous pulsation. Jugular venous pulsation is different from arterial pulsation in neck by following ways. Jugular venous pulsations are less sharp and less palpable, and the, the pulsations C and V can be made out. There is a slight change in JVP during respiratory cycle, but there is no such changes in the arterial pulsation. Jugular venous pulsation can be abolished by slight pressure at the root of the neck. If pressure is applied in the abdomen, the level of JVP rises. Jugular venous pulsation is better seen than felt. So this is the the venous jugular venous pulsation, and you can see here three positive waves, that is A, C and V, and two negative waves, that is X and Y, during different phases of cardiac cycle. Some of the abnormalities of JVP. JVP is elevated in congestive heart failure. A large wave is got when there is abnormal resistance to atrial contraction. Also when there is a narrowing of the AV walls. And giant A wave or cannon wave occurs when there is atrioventricular dissociation. Here atria contracts against the closed ventricle and condition is complete heart block. The giant C wave is seen in tricuspid insufficiency. Coming to pressure changes in ventricle. Left ventricular pressure changes. A small rise in pressure up to 10 mm Hg is seen in the ventricle during atrial systole. At the end of atrial systole, pressure decreases 2 to 3 millimeters of Hg. In isovolumetric contraction period, the pressure increases up to 80 mm Hg, and towards the end of this phase, semilunar walls open. Further contraction is isotonic and the pressure reaches a maximum of 120 to 130 mm of Hg. In the rapid ejection phase, pressure starts decreasing, but it is higher than the aortic pressure. In the protodiastole, pressure again decreases and it becomes less than aortic pressure, resulting closure of semilunar walls. In isovolumetric relaxation period, there is a rapid fall in the pressure. At the end of this phase, pressure becomes less than that of atria, resulting in opening of AV walls. In later stages, pressure falls to base, that is around 1 to 3 millimeters of Hg. So this is the left ventricular pressure changes. During atrial systole, it reaches to 10 mm Hg, and at rapid ejection phase, it is going to reach to maximum up to 120 mm Hg. Then during diastole, it is going to gradually decrease. Right ventricular pressure changes. When compared to the left ventricular changes, right ventricular pressure is less in different phases of cardiac cycle. In isovolumetric contraction phase, the pressure in right ventricle is around 10 mm Hg, and in the maximum ejection phase, the pressure is attained to just 20 to 25 mm Hg. Pressure changes in aorta. Since pumping of blood by ventricle is intermittent, the aortic pressure fluctuates between systolic pressure of 120 mm Hg and diastolic pressure 80 mm of Hg. During atrial systole and isovolumetric contraction phase, there is no change in aortic pressure. Mean ejection pressure in maximum ejection phase, blood is ejected into aorta and the wall of the aorta stretches due to elasticity. The aortic pressure reaches a peak of 120 mm of Hg. In rapid ejection phase, amount of blood ejected into aorta becomes lesser and lesser. The peripheral runoff into smaller vessels become more and the aortic pressure starts to fall. During protodiastole, ventricular pressure becomes less than that of aortic pressure. So there is a tendency of blood to flow back into the left ventricle marked by a depression in caesura. At the end of this phase, semilunar valves close. Closure of semilunar valves, which forms the diacritic notch, causes a momentary increase in aortic pressure, and the blood strikes against semilunar valves, causing a vibration in the blood column called after vibration in the recording, and this occurs in isovolumetric uh, relaxation phase. The aortic pressure falls throughout the ventricular diastole phase. Due to the elastic recoil of vessels, the pressure will not fall beyond 80 mm of Hg. This is the aortic changes, where it can range from the diastolic pressure 80 mmHg to maximum about 120 mmHg, which is going to reach to the peak uh, at the systole. Pressure changes in pulmonary artery. Pulmonary changes are similar to aorta except that the pressure value is less. Maximum 25 mm of Hg and minimum of 10 mm Hg of diastolic pressure are recorded. Volume changes in the ventricles. During atrial systole, the ventricular volume increases, and during isovolumetric contraction phase, there is no change in the volume since all the valves are closed. During maximum ejection phase, volume decreases rapidly, and during rapid ejection phase, reduced ejection phase, there is a decrease. The decrease in volume is less. During isovolumetric relaxation phase, there is again no change in volume. Rapid increase in the volume occurs during rapid filling phase, and slow rise occurs during diastasis. The rest of the filling is during atrial systole. The amount of blood in the ventricle at the end of diastole is called as end diastolic volume, and it is around 120 to 130 ml. So this is the volume changes which occurs in the systole, and uh, and in the diastole the volume is going to uh, the ventricular volume is going to gradually increase. This is in brief about cardiac cycle. Thank you.